Good morning students, welcome to today's lecture. Today we are going to begin with a new topic which is titled Cyst of the jaws and soft tissues. At the end of today's lecture, we will be able to list out at least 10 different types of cysts affecting the jaws and soft tissue of head and neck. We will be able to classify cysts of the jaws. We will be able to describe the clinico-pathological aspects of MUCOCELE in detail. We will be able to identify, illustrate and differentiate the histopathological features of MUCOCELE. We will be able to recognize the significance of a histopathologic report of cystic lesion and suggest the treatment options. Before we discuss the core topic, let us discuss some key concepts. To understand cyst properly, it is important to understand the definition of the cyst. The definition of cysts describes the pathology exactly as it is. So, a cyst is defined as a pathological cavity lined wholly or in part by epithelium, having fluid, semi-fluid or gaseous contents, which has not been created by the accumulation of a pus. So consider a cyst like a sac which is filled with fluid or some gaseous content and is not pus. Cysts basically occupy a space within the jaw or soft tissues, resulting in swelling of the jaw and or the soft tissue. Generally, when a cyst occupies a soft tissue, it results in a swelling which would further result in asymmetry. Cysts occurring within the jaws may not give rise to an apparent swelling. However, it does cause some lytic defects within the bone, which on future expansion may cause swelling or pathological fracture. Different cysts vary according to their origin and can be identified by the type of epithelium lining or based on its location. So, when is a pathology called a cyst? It is a cyst when it is a pathological cavity that occupies space. As we have discussed just now, a cyst can occur within the soft tissue or within the bone. So, it is a pathology which occupies some space within the soft tissue or the bone. It has some content. Because it results in a cavity, the cavity is not empty. It would have some fluid, semi-fluid or gaseous contents within it. It should be noted here that this fluid content is not caused by the accumulation of pus. The accumulation of pus gives rise to a separate pathology which we call as an abscess. So it is important to determine whether the pathology we are dealing with is a cyst or an abscess. We have to correlate the clinical features accordingly to determine this. And as we just discussed, cysts basically cause soft tissue swellings, or it can cause bone resorption or expansion. So here is an illustration of the different types of cysts occurring within the jaws or outside the jaw. If you see here on the right, this is a cyst which is known as OKC. Here there is a cyst which is forming in relation to the crown of the tooth. Such cysts are known as the dentigerous cyst. Some cysts commonly occur in relation to the apex of the root. Such cysts are referred to as periapical cyst, also known as radicular cyst. A similar kind of cyst which are not associated with the tooth are referred to as residual cysts. Sometimes cystic lesions will occur in between the root of two adjacent teeth. Such cysts are known as lateral periodontal cyst. Cysts can also occur outside the jaw in relation to an erupting tooth, which are referred to as eruption cyst, or they may occur in the gingival tissue known as gingival cysts. Whenever a cyst occurs within the jaw, it gives rise to some characteristic radiographic findings. Most of the cysts present as unilocular radiolucency, whereas some may present as multilocular radiolucency. These radiolucencies have a regular or occasionally scalloped borders. Sometimes the radiolucency may be superimposed by some foci of radioopacity, resulting in a mixed radiolucent radioopaque lesion. Some occasions, the cyst may also result in cortical expansion. In such instances, it results or gives rise to swelling of the face. So here are some radiographic examples of some of the common cysts. As discussed before, a cystic lesion occurring in the periapical area of a tooth is also known as a periapical cyst. This cyst gives rise to a well-defined unilocular radiolucency which is present in relation to the apex of the tooth. Cysts occurring in relation to the crown of an impacted tooth are referred to as dentigerous cyst. As you can see in the IOPA here, there is an impacted 3/8 and a well-defined radiolucency is seen in relation to the crown of 3/8. This is a large radiolucency here, but it is unilocular and well-defined. This is a dentigerous cyst. Another characteristic type of cyst which results in large multilocular radiolucencies along with scalloped borders generally occurs in the posterior border of the jaw or the posterior region of the jaw. Such cysts are termed as odontogenic keratocysts. Cysts may also occur in between the root of two teeth within the jaw. This is a well-defined unilocular radiolucency occurring between the two premolars. This is an example of a lateral periodontal cyst. Before we move further, let us understand some other key concepts in relation to a cyst. So to understand a cyst, we should be able to recognize the various parts of a cyst. These parts are common for all or at least most of the cysts which we are going to discuss. So here you can see an illustration of a cystic lesion here. A cystic lesion will generally have three parts. This image here depicts a histological picture of a cyst. So let us correlate this histological picture of the cyst with the illustration for better understanding. So as mentioned, a cyst basically has three well-defined parts. First is the cavity. As we all know, cysts are cavitary lesions. So a cyst will definitely have a cavity. In histological terms, we call this cavity as the cystic lumen. This cystic lumen will contain the fluid, semi-fluid or gaseous contents. The type of cystic contents sometimes gives an indication to the type of cyst. These contents may be analyzed by means of aspiration. The next part of the cyst is what we see here as the second layer. This is also referred to as the epithelial lining or the cystic lining. The cystic lining is what defines and characterizes a cyst. The type and behavior of the cyst is defined by this epithelial lining. As you can see here, this is a cyst which has an epithelial lining which is of the keratinized type. This is an example of a odontogenic keratocyst here. It has to be remembered that all cysts may not have an epithelial lining. As the definition says, a cyst may be partly or wholly lined by an epithelial or may not be lined by an epithelial lining. The third part of the cyst is the outermost part. As you can see in this picture, the outermost part shows collagen fibers along with fibroblasts. This outermost part is also referred to as the connective tissue capsule or the cystic capsule. So, to summarize, a cyst will have three parts. That is the cystic lumen, the cystic lining and the connective tissue capsule. In some instances, there might be an absence of the lining wherein only the cystic lumen and the connective tissue capsule will be seen. This brings us to the next point, the concept of true cysts and pseudocysts. As we had just discussed, a cyst will have the three essential aspects, the lumen, the lining and the capsule. Whenever a cyst will show all these three features, it is referred to as a true cyst. However, we have also discussed that the epithelial lining, the cystic lumen, may be absent in certain situations. However, there will be a presence of a lumen which is bounded by a dense connective tissue capsule. Such cysts have been referred to as pseudocysts. So now we have developed a certain level of understanding in relation to the various cysts of the oral cavity. These cysts are classified into different types to develop a better understanding. So broadly, the cysts can be categorized as non-epithelial cysts, also known as pseudocysts, which we have just discussed, or epithelial cysts, also known as true cysts. Based on the origin, epithelial cysts can further be classified into odontogenic cysts and non-odontogenic cysts. Odontogenic cysts are derived from odontogenic epithelium. The lining of the cysts will have a derivative of the odontogenic epithelium. Non-odontogenic cysts, on the other hand, will have a epithelial lining that is non-odontogenic in nature. For example, it may include a lining which is epithelium or a ductal lining and so on. Odontogenic cysts are the important topics which we have to consider here. A thorough understanding of the common odontogenic cyst is necessary. We will be discussing the odontogenic cysts in the next lecture in detail. So, the odontogenic cysts can be further classified under two broad categories. They may be categorized as developmental cysts, wherein the pathogenesis is related to some aspect of the development of the odontogenic epithelium, or they may be termed as inflammatory cysts, wherein the cyst arises as a result of an inflammatory process. So based on this understanding, the cysts of the jaw are classified into the following types. We have broadly the odontogenic and the non-odontogenic cysts. As discussed just now, odontogenic cysts can be further classified into developmental and inflammatory cysts. The different types of developmental cysts are odontogenic keratocyst, dentigerous cyst, eruption cyst, gingival cysts of infants, gingival cysts of adults, lateral periodontal cyst, calcifying odontogenic cyst, and glandular odontogenic cyst. The inflammatory type of odontogenic cysts include radicular cyst, which is also known as the periapical cyst, residual cyst, or paradental cyst. The non-odontogenic cysts are less common in appearance. They are not related to any odontogenic epithelium and are characterized by the lining in their native location. Examples of such cysts include the nasopalatine duct cyst, nasolabial cyst, globulomaxillary cyst, dermoid or epidermoid cyst, thyroglossal duct cyst. Few examples of the non-epithelial primary bone cysts include solitary bone cyst, which are also referred to as simple traumatic or hemorrhagic bone cyst. Aneurysmal bone cyst is a common non-epithelial bone cyst. Another term which is referred here is the Staphnous idiopathic bone cavity. This entity has been involved or included in this classification because of its similarity to the radiographic appearance of a cyst. However, it should be noted that the Staphnous idiopathic bone cyst is not a true cyst and a radiographic incidental finding. Then we have the non-epithelial soft tissue cysts like the MUCOCELE. So today we will be discuss in detail about MUCOCELE. Other odontogenic cysts will be discussed in the next topic. So here you can see an image showing swelling on the right side of the lip. The swelling appears dome-shaped with the overlying mucosa appearing normal or has some bluish tinge. The clinical presentation here suggests that it is a submucosal lesion. The swelling is because of the event occurring in the submucosa or the connective tissue. Such lesions are the characteristic features of what we call as MUCOCELE. Before we discuss this pathology, let us understand the term first. The term muco means mucus and coelum means cavity. So the term MUCOCELE is basically a cavity that is filled with mucus. MUCOCELE are basically divided or classified into two main types: the mucus retention cyst or the mucus extravasation phenomenon. 90% of the MUCOCELEs are basically mucus extravasation phenomenon, with only less than 10% being mucus retention type. Mucus retention cyst is also an example of a true cyst because histopathologically we will be able to see a epithelial lining in such cysts. However, no such linings are seen in the mucus extravasation phenomenon. Hence, mucus extravasation phenomenon is an example of a pseudocyst. Because mucus extravasation phenomenon is more common than the retention type, sometimes the term MUCOCELE itself is used instead of mucus extravasation phenomenon. However, it is advised that we refer to this pathologies by its exact name for better understanding and to avoid any confusion. So let us begin with the understanding of the pathogenesis of the common type of MUCOCELE, that is the extravasation phenomenon. It should be remembered here that mucus extravasation phenomenon is related to an event of trauma. Acute trauma or trauma induced by dentition may basically result in a severance of the salivary duct. It should be remembered here that minor salivary glands are distributed in different parts of the oral cavity. The minor salivary glands are located in the submucosa, which through the ductal system secretes the saliva, which further lubricates the lining mucosa. So, in event of a trauma, there is a severance of the ductal system. such that the salivary secretion is unable to be secreted into the oral cavity. Instead, this secretion is collected within the connective tissue, resulting in spillage of mucin into the connective tissue. When this occurs, two important events takes place. The spillage of mucin into the connective tissue will distort the integrity of the tissue. The mucin will try to spread. To prevent this distortion, there is a defense mechanism which leads to the formation of granulation tissue. A granulation tissue is nothing but a formation of new collagen fibers for a rebuilding or a defense purpose. In this case, the granulation tissue is formed all around the spilled area of mucin such that it wards off its spread, resulting in a localized area of mucus pooling. The second important reaction which occurs here is an inflammatory reaction. It should be noted here that mucin is not a native component of the connective tissue. Hence, whenever a mucin is spilled into the connective tissue, it is treated as a foreign body and an inflammatory reaction is elicited. Macrophages are recruited to the site of mucus pooling, which will try to engulf and phagocytose these foreign agents, that is the mucin. So this two events results in what we refer to as the mucocele, which results in a swelling. The picture here depicts a mucocele of the lip. It should be remembered here that the lip is the most common site for mucus extravasation phenomenon. Further discussing the pathogenesis of the less common type of mucocele, that is the mucus retention phenomenon. In this type of mucocele, there is no severance of the ductal system. Instead, there is a blockage of the ductal system. This blockage can be built up of some debris within the ductal system or because of a more well recognized pathology which we refer to as the silolithiasis. We have already discussed the pathology of silolithiasis, which is basically deposition of calculi around a nidus within the ductal system, such that it blocks the flow of saliva through the ducts. So whenever this occurs, the mucin which is secreted by the salivary acini is unable to be excreted into the oral cavity. Instead, it begins to collect within the ductal system, resulting in the dilatation of the duct. This collection of the mucin within the ductal system will give rise to a large cyst-like structure, resulting in swelling. It should be noted here that mucus retention cysts are more commonly occurred in the floor of the mouth. The floor of the mouth is an ideal location because of the sublingual glands and submandibular glands. The ducts open against gravity, hence such ducts are ideal for formation of any obstruction, which will result in retention cysts. So here you can see an example of a retention cyst which is present in the floor of the mouth but based around above the muscles of the floor of the mouth. So let us discuss the clinical features of mucocele. As mentioned already, nearly 90% of the mucocele are of the extravasation type. We would be highlighting the clinical features related to the same. The mucocele of the extravasation type occurs more commonly in children and younger adults. Retention type is a common event occurring in older population. Extravasation type of mucocele occurs most commonly in the lower lip because these are areas most susceptible to trauma. Other than that, mucoceles can also occur in the buccal mucosa, floor of the mouth, ventral surface of the tongue and palate. It should be remembered that retention cysts are more common in the floor of the mouth. The clinical appearance of the mucocele depends on its location within the submucosa. If the area of the mucus pooling is in the superficial part of the connective tissue, it will give rise to a swelling which is fluctuant in nature and has a bluish transparency. However, mucus collection in deeper areas of the connective tissue may result in a mass which is not as fluctuant as bluish as the classical feature. Pain is quite a rare feature associated with mucocele. Another type of mucocele, which is also referred to a ranula, is nothing but a large mucocele commonly occurring in the floor of the mouth. The term ranula has been given to such mucocele because it resembles a frog's belly. The large protrusion of the frog's belly is resembling the large mucus swelling here, and hence the term ranula. A variant of ranula, also referred to as plunging ranula, is a mucocele occurring on the floor of the mouth which extends into the neck. Here you can see an example of a swelling of the neck which is secondary to a mucocele of the floor of the mouth. As we discussed previously, the mucocele of the floor of the mouth would occur above the muscles of the floor of the mouth. However, in certain situations, the mucus may seep through the various layers of the muscles, that is the mylohyoid and the geniohyoid, and make its way into the facial planes of the neck, resulting in a swelling. This is what we refer to as the plunging ranula. Radiographic assessment of such regions using CT or MRI will reveal the communication of the ranula into the neck. This finding is referred to as the tail sign. Plunging ranula, it should be remembered, is nothing but a mucocele of the extravasation type. So, here is an illustration which is depicting the same. First image shows a large ranula in the floor of the mouth. Please note here that ranula is still above the muscles of the floor of the mouth. The second image here depicts the extension of the mucus below the geniohyoid muscle, but it is still contained within the mylohyoid. In such situation, the swelling may not be apparent on the floor of the mouth or even on the neck. The third situation here, the mucus pooling has occurred below the mylohyoid muscle, resulting in a well-defined swelling of the neck. This is what we refer to as the plunging ranula. So, we have discussed the classical clinical presentation of mucocele, and hence it should be really easy to diagnose it. However, on rare occasions, certain salivary gland tumors or hemangioma may mimic a mucocele clinically. So, careful examination of mucocele followed by histopathological analysis is necessary to rule out such tumors. Mucoepidermoid carcinoma, canalicular adenoma or pleomorphic adenoma, especially of the nip, may mimic a mucocele clinically. At this point, we have to remember that mucocele are more common in the lower lip, whereas salivary gland tumors are more common in the upper lip. We have discussed this point during the discussion of the topic salivary gland tumor as well. So whenever we come across the swelling of the lower lip, we should consider it to be a mucocele more likely, whereas if we find a swelling of the upper lip, it would more probably mean that it is a salivary gland tumor rather than a mucocele. So biopsy is advised at all times to rule out any neoplastic process or malignancy. Following biopsy, we would see some classical histological findings in relation to mucocele. What we are discussing here are the histopathological features of the extravasation type of mucocele. Three important points or features may be observed in a biopsy specimen. Areas of mucus pooling. The mucus pooling will be surrounded by granulation tissue, which will have a chronic inflammatory cell infiltration, including mucinophages. It should be remembered that the extravasation type is a false cyst and there is no epithelial lining, whereas the retention type is referred to as a true cyst and will show a ductal lining epithelium. Here you can see a low power view of a mucus extravasation phenomenon. This is an excisional biopsy specimen of a small mucocele. As you can see here, there's a large cavity here showing some mucus content within. This cavity is surrounded by a dense layer of granulation tissue formation, which shows inflammatory cell infiltration. Note that this mucus pooling has resulted in a swelling which has pushed the epithelium upwards. Understanding this mucocele better requires a further examination of the edge of the cavity, which reveals the mucus pooling. It should be remembered that special stains like PAS is ideal for confirmation of the mucus content. So we will see a classic magenta colored staining of the mucin within the cystic lumen. Adjacent granulation tissue will show inflammatory cell infiltration. As discussed in the pathogenesis, macrophages are activated in response to mucus spillage to phagocytose them. These macrophages, after engulfing the mucin, will show a foamy cytoplasm. Such macrophages are referred to as mucinophages. It should be remembered that mucus pooling may not be evident at all times in a biopsy specimen. The mucus may be spilled out during processing and may not be evident within the stained specimen. However, it will be possible to locate these mucinophages, which would give the evidence of previous mucus pooling. So remember this as an important point for histopathological diagnosis of a mucocele. Mucus retention cysts, as we discussed, on the other hand, are caused by an obstruction of salivary gland excretory duct resulting in an epithelium-lined cavity containing mucus. Mucus retention cysts are also sometimes referred to as salivary duct cyst. The clinical features of mucus retention cyst may appear similar to that of mucus extravasation phenomenon. Since we have discussed this before itself, that there is an obstruction within the ductal system which results in pooling within the ducts, resulting in dilatation such that it gives rise to a cyst-like structure which is lined by the ductal epithelium. These are the mucus retention cysts. The same features can be identified in the histopathology. Since we have already discussed the various parts of cysts and discussed the pathogenesis of mucus retention cyst, it would be easier to identify these structures. I give you 1 minute time to label these 4 structures. Okay, so the first structure labeled here is the cystic lumen. The cystic lumen shows the mucus pooling. The lumen is surrounded by a lining epithelium. The lining epithelium in this case is composed of ductal epithelial cells. This is further surrounded by the connective tissue capsule. I hope you got the answers correct. If we develop an understanding of the basic concept of a cyst and understand the pathogenesis, it becomes easier to identify the histopathological features. It should be remembered that the histopathological features of different cysts depend on the type of lesion. So understanding the pathogenesis of each of the cysts is important for the same. The treatment of MUCOCELE, be it extravasation phenomenon or retention type is similar. MUCOCELE are reactive lesions and require simple excision. Recurrences are rare in this case. However, the extravasation type has been known to show some recurrences. This is because of the additional pooling of mucus following removal of the previous mucocele. To minimize such chances of recurrences, the feeder gland should also be removed along with the excision of the mucocele. Even though mucocele is a reactive lesion, assessment of such lesions following biopsy is necessary. As we discussed previously, MUCOCELE may mimic as a malignant or benign tumor on rare occasions. Hence, histopathological evaluation makes it important to screen each and every case of MUCOCELE to avoid such diagnostic mishaps. So, to summarize, mucoceles are a pathological cavity which is filled with fluid. We have learned about two common types of mucocele, that is the mucus retention type and the mucus extravasation type. These two types of mucocele vary in respect to the pathogenesis. The extravasation type is known as a pseudocyst, and the mucus retention cyst is a type of a true cyst. Differences are there in terms of histopathology, wherein the extravasation cyst will not have an epithelial lining. On the other hand, the mucus retention cyst will show a lining epithelium surrounding the cavity filled with mucin. I hope the understanding of this topic has been done by all of you based on this lecture. So I suggest all the students to perform some revision exercises following this lecture. If we follow these exercises, it would help in the future understanding of other pathological concepts as well. So I request everyone to prepare a list of cysts based on the cystic content, to prepare a list of true cysts and pseudocysts, to prepare a list of odontogenic cysts and non-odontogenic cysts of the oral cavity, to prepare a list of cysts within bone and soft tissue, to know about stiffness idiopathic bone cavity. Further, I would request all the students to know in brief about the less commonly occurring cysts like nasopalatine cyst, aneurysmal bone cyst, dermoid cyst, etc. In the part 2 of this lecture, that is the next lecture, we will be describing the clinicopathological aspects of radicular cyst, dentigerous cyst, and odontogenic keratocyst in detail. We will be able to identify and illustrate the histopathological features of radicular cyst, dentigerous cyst, and odontogenic keratocyst, and we will also be able to recognize the significance of a histological report of such cystic lesions and suggest the treatment options. Any doubts or clarification in relation to today's lecture, doubts can be posted on the Google Classroom created for the purpose of discussion. We are in the 6th week of the lockdown. I hope everyone are staying at home and stay secure. Please remember to maintain safe distance if you walk out for buying some essentials. Stay home, happy learning. With this, I conclude today's lecture. Thank you.